Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, and welcome to Episode 3 of the Emerging Evidence in Myasthenia Gravis podcast series. I'm Dr. Nick Silvestri, and in this episode, we'll explore how serotype testing informs personalized treatment decisions in myasthenia gravis. You've heard the term, you may already use it in practice, but how are we truly leveraging antibody profiles to guide treatment plans? In this episode, we'll go deep into why serotyping matters, what the evidence says about treatment tailoring, new updates from the AAN 2025 annual meeting, and how to overcome barriers to implementation in real-world settings. So let's first talk about why serotyping matters. Let's get back to the basics. In myasthenia gravis, most pathogenic antibodies target components at the neuromuscular junction. The three clinically relevant that we most often see are acetylcholine receptor antibodies, or AChR antibodies, muscle-specific kinase, or MuSK antibodies, and lipoprotein receptor-related protein 4, LRP4 antibodies. Each of these defines a different serotype with a distinct pathophysiology, clinical features, and treatment responses. That's the crux of why serotyping testing is so powerful. It's no longer just about confirming the diagnosis, but also about personalizing management. Let's start with the most common subtype of myasthenia gravis, acetylcholine receptor positive MG, which accounts for about 80 to 85% of generalized cases. These patients typically respond well to corticosteroids, nonsteroidal immunosuppressants like azathioprine or mycophenolate, and now complement inhibitors like eculizumab, ravulizumab, and zilucoplan. At AAN 2025, a real-world registry showed that acetylcholine receptor positive patients started targeted therapy earlier, within 6 months of diagnosis, achieved faster remission, and required significantly lower cumulative steroid doses than those treated with standard immunosuppression alone. Furthermore, complement inhibitors are not effective in other serotypes, so confirming acetylcholine receptor positivity is essential before initiating these agents. Next, we have MuSK-positive MG, found in about 5 to 8% of patients. This subtype tends to present with prominent bulbar symptoms, facial and respiratory muscle weakness, minimal ocular involvement, and poor or paradoxical response to acetylcholinesterase inhibitors such as pyridostigmine. The pathophysiology here is different. MuSK antibodies are typically of the IgG4 subclass, which do not activate complement, and this explains why therapies like eculizumab or other complement inhibitors are ineffective in this group. Instead, MuSK-MG patients often respond dramatically to B-cell depleting therapies, especially rituximab. So again, antibody profiling changes everything. Let's move on to LRP4 and seronegative patients. So LRP4 positive MG is much less common, probably about 1 to 2% of patients, though possibly higher due to underdetection. The clinical presentation can be milder or predominantly ocular. Importantly, many patients labeled in the past as seronegative were found to have LRP4 or aggregate antibodies when tested with cell-based assays. These patients tend to respond well to conventional immunosuppression, though data on targeted therapies is still limited, though confirmatory trials are needed. For the truly seronegative patients, those patients that do not test positive for acetylcholine receptor, MuSK, or LRP4 antibodies, even more caution is needed. You always need to reevaluate the diagnosis, consider repeating antibody testing, especially with improved sensitivity assays, and ensure thorough electrophysiologic workup. So let's recap the treatment implications for each group. In the acetylcholine receptor positive group, likely effective therapies include steroids, azathioprine, mycophenolate, complement inhibitors, and FcRn antagonists, and less effective is rituximab. Conversely, in the MuSK-positive group, rituximab is very effective, and steroids and some FcRn antagonists, this is emerging data, also seem to suggest improvement there as well. Remember that pyridostigmine or other acetylcholinesterase inhibitors can paradoxically worsen MuSK-positive disease, and that complement inhibitors are not indicated in this group, because again, myasthenia gravis is an IgG4-mediated disease, and IgG4 does not activate complement. In the LRP4 group, you can use steroids, you can use azathioprine or mycophenolate, and possibly FcRn antagonists. And there's very little data about what is ineffective in LRP4 patients in general. And then finally, for the seronegative group, you really need to make sure that that diagnosis is correct and individualized treatment. There's really little data in terms of the use of complement inhibitors. Again, because I have an antibody to identify here and are not sure that if that antibody would activate complement. So tailoring therapy isn't just about efficacy, it's also about avoiding unnecessary side effects from agents unlikely to work. So in terms of new diagnostic tools, what's changed? Several advancements in serotype testing were showcased at the meeting this year. First, live cell-based assays, or CBAs, for LRP4 and Agrin are now commercially available in the US and Europe. Next, multiplex antibody panels are being validated, allowing clinicians to screen for all major MG antibodies with one blood sample, and this reduces turnaround time and improves diagnostic accuracy. What are some barriers to implementation and solutions? So despite the value of serotyping, many clinicians face barriers, such as lack of awareness of available tests, difficulty accessing advanced testing such as LRP4 antibodies, uncertainty about when to test, as well as insurance denials. So how can we move forward? First, educate your team. Include antibody profiling in case discussions and CME activities. Next, use reflex testing. If AChR is negative, automatically proceed to MuSK and then to extended panels if suspicion remains. Next, partner with neuromuscular centers and establish referral pathways to labs offering advanced CBAs. And finally, document rationale. When ordering extended panels, include specific symptom concerns and clinical notes to support insurance approval. Now let's make this practical and walk through a typical clinical scenario. Let's say you have a 38-year-old woman with 3 months of progressive dysphagia, nasal speech, and neck weakness. She has minimal ptosis and no limb symptoms. Acetylcholine receptor antibodies are negative. Repetitive nerve stimulation testing is borderline, and you're considering treating with prednisone but hesitate to do so because of an unclear diagnosis. This is the perfect moment to order MuSK and LRP4 antibodies, consider early referral for single fiber EMG, and hold off on high-dose steroids until the diagnosis is confirmed. And if this patient turns out to be MuSK-positive, early rituximab treatment might be your best next step. This approach prevents ineffective therapy and optimizes her chance for remission. So what did AAN 2025 reinforce? To summarize the key takeaways from this year's meeting: first, antibody status is essential, not optional for MG management. Second, early serotyping testing leads to better patient outcomes. Third, cell-based assays outperform older methods and should be used when available. Fourth, FcRn antagonists show promise among multiple serotypes, not just acetylcholine receptor-positive disease. And finally, serotype-specific therapy reduces treatment delays, trial and error prescribing, and long-term steroid burden. So here's a few final thoughts. The future of personalized MG care. We're moving away from a one-size-fits-all type care in myasthenia gravis. It's not a single disease. It's a spectrum of immune-mediated disorders, and antibody status is the key to understanding where your patient falls on that spectrum. The good news? Tools now exist to make this approach practical and accessible. You don't need to be in a research center to start tailoring therapy. So that's all for episode 3 of Emerging Evidence in Myasthenia Gravis. We've explored how serotype testing can sharpen your clinical decisions, guide therapy selection, and ultimately improve patient outcomes. In our final episode of this series, we'll look ahead to the future of MG care, new diagnostic technologies, guideline harmonization, and what's on the horizon to standardize care around the globe. Thank you again for joining us, and please return to the homepage to claim your credit. And remember, every test you order, every detail you document, and every tailored treatment you initiate brings your patient one step closer to better health. Until next time, keep practicing smarter and with compassion.